with let's start with a recent study that was done by Research America in partnership with the Dana Foundation, in which most Americans have or know someone with a brain disorder. And as we look at the range of issues that are emerging as we are coming out of this pandemic, but many of these issues existed before the pandemic, we see that we have a youth mental health crisis. We have increasing suicide rates. We have health disparities in rural communities and in communities of color. We have an ongoing opioid epidemic and an unprecedented level of overdose deaths that we're seeing in the nation. But we also can be hopeful that research can help to address many of these issues. And so I want to start first with a question to all of you about what should we be expecting from our mental health research agenda in the nation? What are some of the questions that we should be asking? What's not being asked? And what do you hope that our participants who are with us today will take home at the end of this session? So I'm going to start with Bob. If you could talk some about that issue. You're on mute, Bob.
Another technical issue. Anyway, thanks very much for inviting me. You know, as ARC funded a recent study that was published in the Annals of Family Medicine last year that really showed that 85% of primary care practices have difficulty finding advice and services for children with behavioral health care needs in the midst of a huge crisis that we're experiencing that you just described. Now, this difficulty finding primary care providers' advice and services is similarly a problem in looking for services for adults. And what these findings really illustrate is that our existing models of care and the available treatment approaches are failing to address our nation's mental health care needs in this crisis period. We urgently need to improve mental health care and develop a more collaborative model of care. Now, we have a shortage of mental health providers, but we'll never, ever train our way out of this. So, you know, integrating primary care and mental health care is one strategy for trying to expand the availability and the kinds of services that are available across the country. For over a decade, ARC has really championed the need to develop and provide comprehensive, integrated mental health and social care services within a primary care setting. Now, this requires strengthened information systems, scientific evidence on therapeutic approaches beyond those that we're currently relying upon, and new care delivery and financing models. These are all ripe areas for the real-world scientific work that ARC sponsors. For example, ARC's Academy for Integrating Behavioral Health and Primary Care is a national resource and coordinating center for those who are interested in integrating evidence-based care. Now, we need more evidence generated in real-world settings to establish more actionable knowledge, as I like to call it, regarding organizing, delivering, and paying for services, which is the kind of health services research that ARC pursues. Establishing the evidence needed by primary care physicians to serve most patients will free up specialist mental health providers to serve children and adolescents and even adults with more severe illnesses. This is another strategy for addressing the concerns that are identified in that Annals article I just mentioned. Our colleagues at PCORI can complement what ARC's dissemination and implementation work is all about by generating clinical evidence on alternative treatment therapies, especially for children experiencing depressive moods and anxiety. Knowing what therapeutic approach or combination of therapeutic approaches works best for children and adolescents allows ARC to examine how to best deliver those treatments and innovations. I would be remiss if I didn't mention the great contribution of the Biden administration in establishing the 988 Suicide and Crisis Lifeline. 988 is really the first step towards a transformed crisis care system, which includes a chat and text service that connects individuals with counselors for emotional support and other services. From a health services perspective, we need to really understand how to improve that kind of crisis care for a person, and especially for teens in crisis. and the quality of the care and follow-up that's available and can be organized as a result of that one door that's stepping into the healthcare system.
Hey, thank you. Nakela.
Well, thank you so much. It's an honor to be on the panel today, and I really enjoyed hearing Dr. Valdez's comments, and hopefully mine will complement them, because I think in addition to clearly a takeaway today that there's a crisis in mental and behavioral health in this country, is the complementary notion that it's going to take a lot of innovative thinking and the combined efforts of all of us really to move the needle on this crisis. And we know that mental and behavioral health outcomes are really heavily influenced by social determinants of health, which increase people's risk of developing a mental health condition and makes it even harder for them to access quality care, the type of care that we know is difficult to access in this country. But there are also these other factors that you heard Dr. Valdez mention related to coordination of care between clinicians, and we know that coordination of care is actually relatively poor in the United States when it comes to mental and behavioral health, and making referrals and follow-up is difficult, as well as the protracted shortage really of mental health clinicians, which has been compounded by issues during the pandemic. And when we consider all of these issues at PCORI, we've identified some potential areas for comparative clinical effectiveness research on the questions that we're not currently asking that maybe we should be. And one may be about the role that community partnerships and school-based interventions can play in addressing this crisis. Or how might we better address suicide prevention and crisis response, especially for youth, for underserved populations, for older adults who may be particularly susceptible to social isolation. And one of the things that we really enjoy the opportunity to do at PCORI is to engage those that may benefit the most from the research that we fund. And we know that heavily burdened populations are those that are incredibly important to engage to understand the lived experience that will help influence the interventions that will be most effective for them. Another area of focus that has emerged for potential comparative effectiveness research is how best to increase the access to mental health treatment. And this is something where we also have that privilege of being able to partner with organizations like AHRQ, because when we are able to generate that evidence that then can move into dissemination and implementation in terms of healthcare strategies, there's a great partnership and innovation that can come from those partnerships. But CER could really compare brief interventions that could be used across multiple diagnoses, or interventions that leverage innovative and established technologies and culturally tailored approaches really that are targeted at specific populations. We also recognize the opportunities to consider research that compares different care delivery strategies, and, for example, co-location of mental health and primary care, or cross-training of primary care clinicians to better screen and treat for mental health concerns, and team-based models that would include peers or other lay health workers could also potentially increase access to mental health care. And those are the types of questions that we think we can be asking. But there may also be questions about the role of things like implementation science and implementation CER, and how can we get that evidence that is available into the right hands at the right time. And a couple of PCORI-funded studies actually have introduced or indicate even the potential for more behavioral solutions. And, for example, mindfulness-based stress reduction strategies, which have been shown to be comparable in providing relief to commonly prescribed medications for anxiety disorders, or even cognitive behavioral therapy and yoga, which both have been found effective in reducing symptoms of anxiety and worry amongst adults. And there are many other questions we could be asking in that space in terms of the potential for more behavioral solutions. So maybe I'll stop there and hear from the other panelists.
Okay, great. Thank you. Patrick.
Thanks so much, Arthur. All of this must be music to your ears as a great champion for public health. That's what we're missing. We just need a public health system. We need to align the financial incentives to really capture what we all know are the enormous savings through better prevention and earlier intervention. Essentially, what we need is a new, kind of global strategic model from the top down throughout the federal government. And obviously, the financing systems need to be changed in order to finance those care models that you just heard about. The idea that we don't have better data just across the board to measure what works, to support these great leaders in our federal agencies who are after trying to see what works and then implement it. We just need, with the COVID crisis, we can tell in every county and everywhere in America how many people have died, contracted, and what the comorbidities are. That's real time. If we're going to wrap our arms around the real threat that this public health crisis of youth mental health, of course, in the general sense, global mental health is facing, we need to have better data. We ought to be, I'm sure Dr. Valdez, Dr. Cook would like me hearing me say this, but they need a lot more resources to do the work that they're talking about doing today. So not only data, but that idea of IT coordination. How are we going to get data if our IT system in behavioral health, we don't subsidize IT. We do in physical health. That's an example of a disparity that we need to correct in the financial models. And of course, the workforce. So we need to look at this big picture and address all of them, not just one of them, address all of them. And I would just say on a personal level, my daughter was diagnosed with a mental illness during the COVID crisis, an eating disorder, and my family received family-based therapy. Now, I've been a big advocate of mental health my whole life. I have never had a family-based approach, either when I was growing up and needed my family involved, or even in all the years since where I sought treatment. The idea that we don't empower the people closest to the person in a much more comprehensive way and show the value of that. And I know this is part of care models because it is an evidence-based intervention as the family therapy approach, but it's just a perfect example that I have never received it. And I have access to the best mental health care in the country. And I only really got involved in learning how I could help my daughter during the pandemic when virtual care was forced upon all of us. And my wife and I got to be empowered to help our own daughter. And the final thing I would say is I think the elephant in the room is technology. If we could just look at the data on the introduction of the iPhone and social media, on the isolation of our youth and the fact their brains are developing in a different way because they're fixated on screens, as opposed to developing real concrete human relationships. That seems to me like an obvious, but let's bear that out. And anyway, I just am honored to be with these panelists, all of whom are doing just tremendous work. And I just want to see them supported more from the federal government. So I'll pass it back to you, Arthur.
Good, excellent. And Josh.
So NIMH is, as you can see by the logo on my side, has been around for 75 years, and we are celebrating that 75th anniversary and proud of the work that NIMH supported research has done to improve mental health care over those years. Everything from cognitive behavioral therapy that several of the other panelists have mentioned, a key tool in treatment. Nearly every medication under the sun for psychiatry has been touched by, supported by NIMH research, and more recently, coordinated specialty care and evidence-based approach, including family therapy, including many other evidence-based practices that others have mentioned for first episode psychosis, and that has received support, fortunately, from the federal government, and now has a not sufficient, but getting there, public health system dedicated to ensuring that people with first episode psychosis get this evidence-based program of care. So that said, we know we have a lot of work to do, as the other panelists have elucidated. I'm excited about a few different areas that people are beginning to ask questions about, and we need to spend more time asking questions. One of them touches on what Patrick mentioned, what Nakela mentioned. We need to do a better job integrating information that we have about our patients, developing IT systems, using those IT systems both to improve care directly and also to enable research that will be able to build on those improvements in care and demonstrate in real world settings what works, what doesn't. Another area that we need to do a better job is integrating our tremendous wealth of understanding about biological factors that lead to mental illness with the similar wealth that we have about the social factors that lead to mental illness, so that we can begin to get at targetable approaches that will treat and prevent mental illnesses with a more comprehensive and integrated model for how those illnesses really arise. We have some tools that we're bringing to bear in these areas. NIMH has been supporting for the last 4 or 5 years alacrity centers that seek to develop and implement technologies to improve mental health care in real world practice settings. And these centers have really already begun to revolutionize approaches to suicide, management of suicide in youth, for example, where digital approaches are doing a better job detecting risk and intervening in moment, as opposed to when the youth happens to approach a caregiver. So how we maximize the input from all this research and get it into practice, I think, as all the panelists have touched on, but especially Patrick, we need a concerted effort. We need a system that is equipped to be able to take evidence-based practices and implement them on a nationwide scale. And that is a big challenge that we have to address. And those are some questions that we're really barely beginning to scratch the surface. What sort of healthcare systems enable the best use of evidence-based practices? And how do we then implement those practices in those healthcare systems? Thanks for the opportunity to participate with this really wonderful panel.
Sure. Well, this was a really great opening, because what I think you all did is to really show the breadth of issues and questions we should be asking through our research agenda, from basic research to services research to even policy level research, that it's going to take all of that to really figure out how we move our agenda forward. I want to talk a little more about specifically the youth mental health crisis that we have in the nation. The Surgeon General issued an advisory on the crisis. Other organizations, including ours at the American Psychological Association, have noted that we're having a significant series of issues with our youth mental health. And I want to start, Nakela, with you, and if you could describe PCORI's mission and how, on this issue of youth suicide, the kind of work that you all are doing that you think will advance our understanding and solutions for addressing this crisis.
Certainly, and it is such a devastating issue that it really does take all of us to think about and address. And one of the things that PCORI does in terms of its mission is to try to generate the evidence that will help inform the clinical decisions that patients and families and caregivers, as well as the broader healthcare community, have to make on a regular basis. And we do that by funding patient-centered comparative clinical effectiveness research. And mental and behavioral health generally has been a really large area of focus for PCORI, and by some margin, really the largest category of our funding. We've funded over 170 studies in mental and behavioral health for nearly $900 million to date. But if you start to look at this issue of children and youth specifically, there are just a couple of studies that maybe I would highlight to kind of characterize the types of things that we fund in our portfolio on this issue. A study actually that was completed just a few years ago compared 2 different approaches for improving Latino patients, parents really, their activation skills when parents are trying to help their children get the care that they need. And the study actually found that parents who participated in an educational program showed more improvement in these skills than parents that were simply in a support group. And these parents also improved their skills in being able to work with their children's school systems and became more involved in their children's lives. And so the type of CER that we fund that really is addressing some of the youth mental health issues starts to take into account the experiences of patients and their families, as well as the populations that may be most adversely affected, to really understand what's going to work best for them. Another example is a school-based intervention, and we talked about school-based interventions being a possible approach that we should explore more. And this study compared 2 modes of support for students with autism spectrum disorder or attention deficit hyperactivity disorder. And one was this program called On Stuck and On Target, and it helps school staffs actually teach the students how to plan, set goals, and be flexible. And compared to what they were doing in their usual support program, this type of program improved the behavior of students that had autism spectrum disorder symptoms, whereas the usual supports didn't. But both programs actually improved the behavior for students with ADHD. And so what we're learning from studies like this is how we actually mobilize the communities where individuals are embedded to think about interventions that may not always be in the healthcare setting. Knowing that we have the ability to mobilize those outside of healthcare may also improve access. And, we've also been thinking more specifically around suicide rates for American youth. And we know they've been on the rise for the past 15 years. It's the second leading cause of death amongst ages 15 to 24 years of age. And in 2021, we actually approved about $60 million in funding for studies to compare the effectiveness of interventions to reduce suicidality and improve outcomes for adolescents and young adults, with a particular focus on culturally adapted interventions for very specific populations. We're excited about the studies that have been funded there. One's comparing approaches to suicide prevention amongst teens who have already exhibited suicidal behavior and who are identified at medium or high risk for suicide. Another is actually looking at emergency department care and individuals that are young people presenting in emergency departments. And another is actually tailoring prevention strategies to really understand the outcomes for certain youth populations that have higher suicide rates. And so these are the types of things we think are going to be critically important to, number one, get to the populations of highest burden, tailor culturally, and also think about those systems of care outside of the usual clinical interaction to really embed in communities to help intervene on the problem.
Great. Patrick, you were talking about your daughter and some of the challenges, and I was struck by the fact that we've long known that family interventions are critical if you're working with youth. From your perspective and the Kennedy Forum's perspective around this issue, what is it that we could be doing more of, and the kinds of things that you think we should be focusing on when it comes to youth?
Well, I feel, just from the vantage point as someone who spent my life in politics, that we need some political science here. And that is, we need to build coalitions. We need to get the big children's related organizations, NEA, AFT. We need to get all of the youth folks just across the spectrum, not having to just focus on that. And we need to make this their priority. Because this is about trying to implement the incredible evidence that all of our leaders on this panel have worked on. And the only way that gets done in terms of implementation science is how do we implement, the kinds of lessons learned that have come from these federal research institutions. And in my view, it's building a movement. When we've seen great progress, Autism Speaks just totally brought together the whole community. Whether you're Chamber of Commerce or AFL-CIO perspective, the idea that people are coming together to have an impact by really prioritizing big things. And the literacy part that was just spoken about, we need literacy kind of amongst the policymaking community so that they know, whatever committees they are on in Congress, what they can do to advance this. Because I guarantee you, Arthur, all my colleagues, irrespective of party, are looking to be helpful. They know how critical this issue is in their own congressional districts or states, but we need to empower them to do what's going to be helpful. And so getting them kind of the answers to the test on what committee they're on so that they can know what things that they can do in their own committee, so they don't kind of feel, oh, that's the Labor H committee, I can do nothing on that. Whereas they might be unaware that housing is crucial on the Committee on Housing. The Department of Education is crucial, that, getting CMS to really inform more states about getting their plan amendments to ensure that schools are site of service for a Medicaid reimbursement. I mean, that or general reimbursement. Can you imagine blowing out a school nurse's office to be doing telemental health consults throughout the day, especially amongst those underserved communities that will never go after school to get mental health treatment? These are all things that you and I know. We talk about it all the time, but I can guarantee you there is a lost in translation in terms of informing public policymakers to know what to do and to take the advice of these panelists as to what will help us address the problem.
Right. So it's not just about producing the research, but we really have to have a strategy around how that research gets disseminated. I absolutely agree with that. As a former policymaker, I absolutely agree with that. Josh, we saw a question about prevention in the chat, and I know NIMH does a whole range of research, and just wondering on the youth mental health topic. Is there some research that you're doing in the prevention area, or other types of research that you think might be helpful here in advancing our understanding?
Well, first, yeah, absolutely, Arthur. Let me first say that school-based mental health, as the other panelists have mentioned, is a crucial preventative arena. Lots of different interventions have been shown to be effective in the context of school-based mental health, whether we're talking about social behavioral learning programs in preschool and early elementary school years that have been shown to reap benefits years down the line, or mentorship programs that in middle school that reduce all-cause mortality 10 years later. I mean, there's some really remarkable effects of these early childhood and school-based preventative intervention programs that have been demonstrated in the kinds of studies that we support, but have run into challenges in terms of implementation. I remember one preschool researcher said that she had shown in tremendous effects of the intervention that she developed, went to the local school board where the research was taking place and said, okay, I will help you train up all your teachers to be able to do this. And the school superintendent was like, my teachers don't have time for that. They have to teach their kids ABCs, and it went nowhere, even though the results were just so remarkable. Let me also say that in addition to school-based intervention programs, we are conducting lots of research in other areas of intervention. And one of the most promising measures is in that family category. So NIMH-funded researchers have examined, for example, the impact of parental involvement amongst other neighborhood and family factors in building social and psychological resilience in children, and found that parental involvement, number one, is positively correlated with all forms of resilience, and number two, can be taught. So that interventions like the family checkup prevention program done early in early childhood can have significant effects on youth suicide risk years later. So these preventive interventions in schools and in families can play a very important role in reducing risk for mental illness, risk for outcomes like suicide amongst our youth if implemented more broadly.
Excellent. And Bob, what is your take and HRQ's take on this issue of youth mental health?
Well, I'm really glad about this discussion around the issue of really getting national dissemination and implementation, a real strategy there, because that's really at the fundamental area that we're leaning into at ARC. It's part of our mission to improve healthcare in the United States for everyone. And while we support developing the science evidence, every study is just one piece of evidence. And what we try to do at ARC is look at the body of evidence so that we know what I called before actionable knowledge, so that we know actually what we can say works. And an example of that is the U.S. Preventive Services Task Force that we support recently put out recommendations for screening for children and adolescents around mental health issues. And that screening is the first step to actually identifying the children that need assistance and need help. If they come in for a physical health service and they get screened, then we also know the whole person that we're looking at. Is it both just the physical? Is it just the mental? And we can't separate it any longer. We've got to really understand how to get that information out. And we need to get the kinds of studies that my colleagues are doing understand what the body of evidence says we know, and get it out to the communities, and work with our political leaders and others in the local states and localities who really make those decisions, who make those resource allocation decisions, and as well as healthcare executives and trustees who, quite honestly, need to look at the quality of the product that this industry produces. And it is an industry. And I don't know of any other industry that doesn't look at their product and look at the quality of the product that they produce. And so what we're trying to do is really assist healthcare executives, trustees, and other decision makers understand what the actionable knowledge is and to take action.
Right. Well, it looks like our time is up, but I wanted to ask each of you, you have about 30 to 60 seconds as a wrap up. What is the one thing that you'd really like for people to understand around the issue of mental health research? What's the one thing that you'd like for people to kind of leave this discussion understanding? I'm going to start with you, Josh, and then we'll go to the other panelists.
I think there's a misunderstanding in popular culture that most of the things that work in mental health have been discovered by accident. And I think it's important to recognize, as you've heard over and over again, that research gives answers, and paying attention to that research and figuring out ways to use that research to change policy is an effective way of improving public mental health. And some of the examples that we've given over the course of the last hour really underscore that.
Great. Nakela.
Well, I've just enjoyed being on this panel, and I really am glad to hear a lot about this conversation around the importance of nimbleness and flexibility to rise to an occasion and working across sectors. And, you know, Congress authorized PCORI as an independent, publicly funded nonprofit organization for exactly that reason. There are many unanswered questions, many things we know work, and that's where the importance of implementation science comes in. And maybe the very last thing I'll mention is the importance of taking a health equity approach and focusing on the social determinants of health and the interventions in that lens. And I look forward to seeing us take action on some of this work.
Great, thanks. Bob.
Well, I think we should take to celebrate what we do know, because we do know things that work, and that we should make sure that everybody has access to it. And part of that is really understanding how we organize and deliver services and have decision makers take up those actionable pieces of knowledge and really make sure that everybody can benefit from it.
Okay, and Patrick, take us home.
Thanks, Arthur, and it's great to be with everybody. So in Rhode Island, we had all the payers contribute in what the percentage of their market share represented to a prevention pool that then could be paying for things that individually none of them could justify on their balance sheet. We need to come up with better reimbursement systems. We need to have CBO, General Accounting Office, come up with real accounting so that we can improve the percentage of premium, Arthur, of our healthcare dollar that goes to prevention. Unless we show this as a strategic policy objective, we're never going to be able to implement all of these great suggestions you've just heard from the panelists. So we need to have a strategic goal and plan, and we have to come up with fundamental reorientation of our reimbursement systems to incentivize investing in that plan, because our current model of quick ROI just doesn't justify the kind of real ROI that comes over the years that you've just heard these panelists speak about.
Great, and thank you. As I said in the beginning, I thought this was going to be an excellent panel, and they did not disappoint. Thank you all very much for joining us. Thank you, panel. I think our audience is much more aware and understanding of the range of things that we have to look at if we really want to advance mental health in the nation. Thank you for your time.
And I want to chime in and thank you first and foremost, everyone, for your patience with our technical issues at the top. And I want to thank our panel for starting off our forum, our two-day forum, with just a really important and deep discussion. Now let's head back to the lobby for those of you who are on the webinar for our next session. And this will be an update on the Inflation Reduction Act implementation. So we'll see you over there.